So what are the implications of a dual diagnosis, that mental illness and intellectual disability in combination? The first is that the individual is more likely to have a heightened risk of incarceration or institutionalization. And that's because the system out there right now is equipped to deal with people who have mental illness. That's typically something we see happening under a healthcare regime, Ministry of Health funded services, or a person who has an intellectual disability, and those are services typically provided through Community Living BC. But there is this gap for people who have particularly strong, severe symptoms of mental illness and particularly complex issues with their intellectual disability. And these people may either find themselves engaged in a system where their own personal safety is at risk or where the safety of others is at risk. Perhaps they've engaged with the legal system, and people are not quite sure how to create a system or a service for them. Often that service ends up looking like more supervision from staff people or having some of their freedoms limited. Now, I'm not commenting on whether or not that's a good idea or a bad idea, but simply that it is something that we commonly see, where facilities are staffed more highly, where locks are more likely to be seen, where there are restrictions to be in place. And in the case of some of the people I've supported over the years where they became engaged with the courts and where it was evident that the person had an intellectual disability, the courts sometimes directed agencies to provide these type of services out of a recognition that they would have been particularly vulnerable if they had gone into the population either in a correctional facility or even in a psychiatric type of facility, because the individual often lacked the self-care skills, the personal advocacy and communication and social skills to interact safely in those types of environments. Institutionalization doesn't refer only to the idea that people are locked up, but just that there is more structure placed around them, less freedom, less autonomy, and more of a system that is governed and supervised by other people, particularly professionals who are paid. The person may also find that there are procedures in place or protocols that describe physical and medication-based controls, such as restraints or PRN medication, and in some particular cases, there may be a collaboration between professionals to go beyond what is normal, what is the casual or usual intervention, and actually use things such as passive restraints or even isolation rooms and so forth. That's unusual, but I have worked with individuals for whom their behavior, especially towards themselves, could be potentially so dangerous that they needed these types of supports. As a result, the person often has less privacy in their life. They have a higher ratio of staff support, or the other option is that they are placed in places with people who are overwhelmed and really not adequately equipped to provide for their needs. This can mean a more stressful lifestyle for the individual, and that, of course, can mean that this stress aggravates their mental health symptoms. Instead of making things progressively get better, they instead progressively spiral down and get worse. The person often lacks self-care skills, and that results in them having reduced physical wellness and comfort, and that again spirals in. If a person, for example, isn't able to monitor their own hygiene, their nutrition, and their sleep, we know that that's going to have a deleterious effect on their mental health. Why is it more challenging to diagnose or treat a person with a dual diagnosis or a concurrent disorder? Well, it's hard sometimes to determine whether the symptoms are developmental, psychiatric, or behavioral, particularly if we're dealing with individuals for whom communication deficits exist or the quality of the person's alertness and lucidity is affected. The individual's behavioral patterns are sometimes very, very old and long-standing, and sometimes the tracking or the data, the historical collection of data, is not where it should be. Sometimes people's data is very subjective or incomplete or simply missing. And so it can be difficult to tell whether or not what's going on is a function of just normal developmental influences, whether it's a psychiatric symptom, or whether it's something that is purely at what we call behavioral root, meaning that it's about what's happening in the person's life around rewards and consequences, whether we can shape that behavior really by doing something as simple as a behavioral program, or whether we need to use medication. The good news is that often it's best to take a comprehensive approach and connect all of those things as well. And if we do that, it's sometimes less important to worry about the particular idea of whether something is psychiatric or behavioral. We also need to have a sense of whether the disorder is primary or secondary. And again, we've spoken about this in other modules. Is the person, for example, using a substance because of the fact that they have a mental illness, or do they have a mental illness as a result of having used the substance for an extended period of time? The client may have a limitation, as we said a moment ago, in terms of their ability to share diagnostic information. They may have a poor knowledge of their history, they may have a limited ability to communicate, or they might have had some very poor experiences in engaging with professionals in the past and may be very reluctant to share anything about their particular conditions or to trust the advice or guidance of a clinician. Some methods may not work in terms of treating that individual. For example, if the individual has communication or social deficits, then talk therapies such as group therapy and so forth may not be particularly effective. The same is true about anything where an individual might have to do a self-help type of protocol, such as anything where they have to read a procedure or record and track. For example, it's common to ask people to journal, and that may not be something that an individual can do if they have an intellectual disability or if they simply have an impaired cognitive ability as a result of a substance. And in some cases, it may not be possible to allow people to self-administer medication because of the fact that they have either had a history of drug abuse or because they simply aren't capable of discriminating in between the safe and appropriate use of their medications and unsafe use. In some cases, the developmentally disabled or intellectually disabled client may be very confused regarding professional roles. It's a very foreign thing if you think about it, that on the way to the doctor's office you may ride the bus and sit beside somebody wearing a white coat, but you wouldn't dream of telling them about your bowel movements. You go into the hallway of the medical facility and you walk down it and you see lots of people with white coats, but you wouldn't dream of telling them about your bowel movements. You go into an office and there's a person sitting behind a desk punching numbers into a computer, and you tell her that you're there, but you don't tell her anything about your bowel movements. And then at exactly 2 o'clock, you go into a small room and you talk to a person who's wearing a white coat, and you tell them all about your bowel movements, and this individual writes you a prescription or sends you a referral notice, and as you walk out the door, you again must remember not to tell anybody else about your bowel movements. That's a very strange social construct and very difficult to explain to somebody who has social deficits, and that's very much the case with many individuals with intellectual disabilities or long-standing drug use and so forth, where their social learning may have been deprived over a period of time. And simply a lack of appropriate services and expertise may exist for that individual, again, particularly if they live in remote areas, as we've spoken of earlier. All right, let's write something in our journal. Based on what you know now, briefly describe the symptoms of schizophrenia, and this will help us to introduce the next video. And were the Greeks correct in labeling this disorder split brain?